So at Paul, we have 4 true beams, and we've been doing tattooless for a few years now. And head and necks are really the only site that we're not using the SGRT for other than electrons. So sort of the next step really was to see what we could do. So these are the masks that we use at the moment. We all know their sort of benefits and negatives. So they cause claustrophobia. We've got lots of things about how much claustrophobia they cause when patients have them. So we thought, well, what could we do to help with that? So we were talking to the people from lots of different vendors, and we discussed this with Macromedics, and they said they were talking about using the DPS prominent, DSPS prominent, without the top half, basically. And we thought, well, initially thought that seems a bit crazy, but we looked into it a bit further, and they put us in touch with this team from the Netherlands and who published this feasibility study, who were having really, really good results with it. So we thought, well, we'll have to do some of our own tests and see what we think of it. And we wanted to see basically what, could it reduce the patient's anxiety? Does the SGRT help with, can it monitor the patient while they're in there, and does mask actually immobilize them? And just before we started, we heard from Macromedics that the team from Le Havre, Jonathan, was also doing a very similar thing, and so we got in contact with them and had a good discussion about what they're doing, and they started just before us, so they had a couple of patients, and it all seemed to be going really well with them as well. And so we were sort of looking at what it is that we wanted to get from it. Like I said, we want to check how the patient's experience is like. Is it better? Is it the same? In theory, you think it would be better to not have the mask on top, but we thought we'll check those sorts of things. Is the patient actually immobilized in the mask? And if they're not, is the SGRT picking up if they do move? So what do we do? So the first thing, we do daily CBCT on all of our head and neck patients, and so we decided we'd have a sort of comparison between 25 head and neck in a closed face mask and 25 patients in these occipital masks. And so we could use the interfraction motion using the pre-treatment CBCT, and then we do a day 1 and a weekly post-CBCT as well to track the intra-fraction motion, as well as using the SGRT data for each fraction as well. But that's on that sort of side, my colleague Toby has done lots of good work in looking at that, but I hadn't had time to put it all on the screen yet. So we did have specific criteria in which the patients that we selected, including, because at the moment we don't position bolus and things like that with the mask, with the SGRT, and with our closed mask patients, we stick the bolus to the mask, and so there was sort of an extra solution you'd have to find, and we decided that we would look at this first and then worry about that afterwards. And we gave our patient experience surveys to the patients to sort of get how they felt about, to understand how they felt about having the mask done and if it caused them anxiety and things like that. So it's just a picture of the mask. This is one of my colleagues in it. One of the problems we had with selection was basically, I think Hannah sort of talked about this roughly, was that the frame that the mask sits in is, this is the only one, and it's a specific size. So if the patient is they're too wide, or their head doesn't, or their neck isn't, if they don't have a very long neck, so their head sort of fits in this part, it can be quite difficult to fit them in the mask. And so there's quite a few patients, we managed to get a good number, but there are patients who just don't fit in the mask. They also need to be able to lie down flat, because you can't raise the frame, so if they can't lie down flat, they can't go in it. And also just to exclude anybody who had any conditions that made them not be able to stay still, like Parkinson's or anything like that. So initially, these are sort of the ROIs that we started using. I had one for the face for the treatment, and then one for the shoulder position for setup. But we sort of found that it can be quite difficult with the shoulder position to understand what the TLDs are telling you, because if one of the shoulders up and one of the shoulders down, it's difficult to visualize what that means from just the numbers. So we started using the postural video quite a lot as well to really position the shoulders, because it's a lot easier to sort of visualize where the shoulders need to be using the postural video. And this is what we sort of found from it. So in terms of patient experience, this is the first 14 patients, because the other ones are either still on treatment or like in planning. 71% of them had no anxiety making the masks at all, which is obviously very beneficial, and 90% of them didn't have any claustrophobia about having the mask made, and just had quite a positive experience. I mean, a lot of them would say about how they were quite worried about having the mask done, and when we gave them this option, they were very happy to do it. The way that we sort of selected the patients was very much that we gave them the option, so you sort of made sure that they fit in the criteria that we want, and then we gave them the option of having one or the other, because you don't want to force them to have something they didn't want. And then we have the interfractional motion results on here. So as you can see, they're very positive. They're very, very similar, and not really clinically different. Obviously, this is the setup. How much of a shift you've had to do once you set the patient up. So it's important, but it's not. I think the intrafractional motion is just where you want to make sure the patient isn't moving during treatment. So this is always very positive for us at the beginning. And then for the intrafractional motion, it's also, it's not clinically any different. It's not clinically worse. If anything, for the translational shifts, it was slightly better, and for the rotationals, it was slightly worse, but well within what you sort of happy to accept. And we also have some data from Jonathan from Le Havre, and their first, I think it was 9 patients, I think, for this one, and they show very, very similar things where it's all well within what you would accept for our closed phase patients compared to these patients. So we were very, very happy with that. The main limitations we found with them was basically the setup times. We did find that the setup times were longer, and it varied quite a lot depending on the patient or the experience of the team who was doing it. If the team's got a lot of experience doing it, it can be done quite quickly, and if for whatever reason, what we tried to do is we tried to keep all these patients on the same machine so that the same team could gain experience with it, and then they would have. But what it's like, things have to get mixed around every now and then, and if you end up having somebody who isn't so experienced with it, it can be a bit more challenging for the setup for them. And you have to provide a lot of additional training. I mean, we spent quite a long time at the beginning before we started having macromedics come down and do some training with people, and then we did some in-house training as well, just to get everybody prepared. But like I say, you train people at the beginning and then they use the system. But if somebody was trained at the beginning but they haven't used it in a little while, and then they come back to using it once those things get mixed around, it can be a little bit more challenging, especially when there are specific patients who need specific things you need doing to them. One of their shoulders needs to be a little bit higher than the other one, or these sorts of little adjustments that if you're used to that patient, that you know what to do. But if you're not used to it, then it can be a little bit more challenging. And the other thing is that they do cost more. Unfortunately, that is the reality of these things, is that they are significantly more expensive than our closed face masks, even than the open face ones that we're sort of looking at in the next few weeks. So you have to sort of take that into account if you can get that past the people above you that you can afford to pay the extra cost. and what sort of benefit it brings for that additional cost. And, you know, we did have, the other thing to consider is we have had we have selected these patients, so in theory these are sort of, you know, it's a relatively small cohort, it's only 25 patients, and this data is only for the first 15 as well. And, you know, these patients have been selected by us as, you know, they're the patients who wanted to do it, and they're not, you know, patients who may get more benefit out of it, or may have more issues. We might have, you know, decided not to do because they had lots of movement, so we had lots of movement when we were checking them at CT, so we decided, oh, we're not going to put them in it, so it makes us look better, when the reality is that it might not be suitable for all patients. And so it's not like, from my point of view, it's not a solution for all patients. It's an option that we can use for patients who really benefit from it, or that you know, want to use it. But like I said, there are limitations about being able to fit in the shell and lie down and that sort of thing. But like I say, all the questionnaires were very positive. All the patients, you know, on day one, the patients would come around and they'd say, "Oh, I'm so glad I'm not having this mask." And the interaction, inter and intra-fraction motion, has all been very positive. I know it's all been well within what we would accept for our closed face mask patients. And this is some of the quotes from some of the patients that wrote in their little surveys, and what they wrote about their experience having the mask made. And like I say, they're all very positive. Well, they'll feel secure, or they were worried about feeling claustrophobic and about having their mask made. And one of the patients, this one, had was very swollen because they had like surgery on their face, and so their lips and their face were all very, very swollen. And initially we were worried about whether or not they would be able to, how the SGRT would track them as they go through treatment, because of the swelling, or if they're swollen at CT and then the swelling reduces. But he was actually really good, and the SGRT worked really well with him. And what we're sort of, the future, hoping to sort of help other places who are thinking about doing the same thing, and you know, look at what other patients to be able to do it. You know, like we look at solutions for our bolus. We don't have a solution for the bolus, so if we can introduce it for those patients, and if we can do it for, like you say, you're doing it for the lung savers because of the shoulder position, like those sorts of things, and you know, and like brains or palliative patients and things like that. But overall, I think, in terms of what our data has shown, it's all been very positive. I think it's more about ensuring that the staff are happy with what they need to do when things aren't necessarily going right, or how to set the patients up and make sure those patients have the best sort of position to be in. This is just some thanks to the team at Paul, who've been really, really helpful. I couldn't have done it without them. And in terms of the SGRT data, like the intrafractional data, my colleague Toby, who's over there, has done lots of work in looking at how many times the patient moved out of position, what their position was for each fraction and overall. So if anybody's got any questions about all those sorts of things, Toby would be very happy to answer those sort of things.